Hello and welcome back to ECAPS Watch. I'm Kevin Houlihan, the CEO at Workflow Services. Today, I'm very excited to be joined by Amanda Meeker. Amanda serves as the immediate past president and legislative chair of the Oregon State Pharmacy Association, where she has led successful efforts to advance pharmacy practice and payment reform at the state level. And she has over a decade of experience serving Medicaid and Medicare patients as a managed care pharmacist, helping shape pharmacy benefit policy, formulary strategy, and clinical programs to support access to care. So, Amanda, you've got quite a unique and exciting background to be able to chat with today. We're, of course, here thinking a bunch about the ECAPS legislation to expand the ability of pharmacies to do point-of-care test or treat for respiratory encounters. But I think to take just a divergence for a second, there's a kind of a relevant part of history that you've been involved with around just the legislative expansion in general to be able to provide more types of care. And so when we caught up before we started recording, you were talking to me about your experience with the legislation around medication as a treatment for opioid use disorder. And so can you share a little bit about some of the history with that and the road it's taken to get that to become a reality and kind of the benefit that you see?
Yeah. So Oregon, a few years ago, passed Measure 101. It was a bill, a referendum to decriminalize hard drugs in Oregon. And the hope was that then those people would get into treatment and that would help cure their addictions. We didn't quite do the second part of that. We did the first part. And so there was a lot of problems in the community with people just openly using hard drugs on the street. And so they went back a couple of years ago to fix the part of the bill they didn't quite get right at the beginning. And as part of that fix, pharmacists were thought of as a place where they could increase access to drugs for medication, a place where people could come to get medications for opioid use disorder. Mm-hmm. And pharmacists could be a bridge if patients had access problems. So if they couldn't get in to see their provider, if there was problems for some reason, they didn't have refills, the pharmacist could just help kind of bridge that until they could get in to see their provider. The legislators came to pharmacy and said, how about if we guys give you guys the ability to fill medications early? And we said, mm-hmm. Okay, well, I don't know how that works. We can already fill medications early if people have problems, except for controlled substances that I see too. So that would be the methadone, which is a drug to treat opioid use disorder. So I said, well, what would really be helpful is if pharmacists could be recognized as a mid-level provider with the DEA so that we could prescribe these drugs and get patients the access really through that way of actually managing their prescriptions. Mm-hmm. And the legislature wasn't exactly willing to do that the first round, but we did more education in the meantime. And then the next year, there's obviously some things that need to be fixed with the fix to the bill. Mm-hmm. And so they came to us and said, does anything need to be fixed on your end? And we said, yeah, can we just get rid of the early refill part of this bill and just expand it so that pharmacists can take care of patients who need these drugs? And they said, sure. So at that point, we were able to get legislation passed that just basically lets pharmacists, through either a statewide protocol or an agreement with a physician, take care of patients who need access to drugs, to medications to treat opioid use disorder. And so, it wasn't the first time. It was the second time where we'd done some education and really helped them understand what the real need was, especially for patients in rural areas who maybe couldn't get in to see a provider every 30 days, to help that pharmacist be able to sort of manage the medication aspect of it, let the providers provide the medical care in the other areas they need to, but to really help the patients not have these gaps in care and to be able to have pharmacists take care of patients who needed it.
Yeah. So there's a couple things that came up that you mentioned a few times there, actually. One was education and the other was access. And so you mentioned briefly that one of the key parts is access in rural communities. And I assume a big part of that is, folks might be living out far from a traditional provider that may have been a key part of them getting access to these important medications, but there's a pharmacy near. And so this legislation kind of makes it so that it's much easier for a patient to access some of this care. I mean, did you see examples of where when there was a significant distance component, that could be a problem or a challenge or?
Yeah, so we're seeing in Oregon, we're seeing providers leave rural areas. So, we have areas on the southern coast where they might have one provider taking care of 50 square miles of patients, and if they are not taking care of patients who have opioid use disorder, if they're not actually providing that service, then maybe they have to drive an hour and a half to a population center like Eugene, where they have providers there who can do that. And there is a very large access problem with all types of healthcare providers in Oregon right now, even pharmacists, unfortunately. And so allowing pharmacists to do more, to take care of more patients and more patients' issues really helps relieve the stress of those patients who can't find somebody who even can help them manage their conditions.
Yeah. So that's interesting. So we've been talking about access to care for opioid use disorder, but it seems like the fundamentals of that, especially from a geographic perspective, ring true for what ECAPS is trying to do, right? So if I'm an hour and a half from my provider for any reason, if I feel like I've got strep or the flu or RSV or whatever, the ability to get a point of care test and treatment right in my community from the pharmacy can be pretty game changing in many patients' lives, right? I mean, there's really no difference. The benefit to opioid use disorder should carry over. Do you think that's right?
Right, exactly. Yeah. Patients go when they don't feel well or they want to know what's happening. They go to their pharmacy. They ask for suggestions. A lot of times now, we have to refer those patients to a provider who can do those point of care tests to make sure that they, get treated appropriately. But having the ability for pharmacists to do COVID tests or other respiratory tests could help get that patient. First of all, they're not spreading it around in the community even more so than just going into their pharmacy and asking for it. They're not then going to the doctor and coming back to the pharmacy. And it will help decrease that wait time for them to actually get to treatment. With a lot of these, it's important to get treated very soon so that the medication actually has a chance of working.
Yeah. Yeah. And that's the kind of thing that ECAPS can help with. You talked a lot about education was a key component of getting that legislation passed in a way that you think is beneficial. Any experience in there with what it took to effectively educate the legislators or the community on the need for this kind of education? Is there anything that we learned there in Oregon that we can potentially use for the process to get ECAPS passed?
Well, I think it's important so we have currently the chair of our House Healthcare Committee in Oregon we've done a lot of education with him. We've done a lot of just like face-to-face on various topics. But having done that and having him have a relationship with the pharmacy in his district has really helped us with that relationship. And now, he's the one actually. So in Oregon, we currently only have COVID test and treat as actually in statute as scope of practice. And so this upcoming legislative session, that'll be expanding hopefully to all respiratory viruses and possibly strep. I'm not sure. Anyway, so that was actually his idea. He came to us and said, I think, we had a bill that didn't pass last year that was in the test and treat space. He said, hey, that this might be a good fit for what we're doing over here this year. So he opened that discussion with us about what could fit into that bill. Doing that education, having him have a personal relationship with the owner of a pharmacy in his district has really helped us in getting him to a point where he's now coming to us and saying, hey, how do we help together help expand access for all the patients in Oregon.
Yeah. So one of the things that I'm excited about with the ECAPS legislation, I keep tracking, is it continues to get more and more co-sponsors in both the House and Senate every week, basically. So if you could talk directly to a congressperson that hadn't yet co-sponsored the bill, what would you educate them on? How would you try and encourage them to consider becoming a co-sponsor?
Yeah, I think I always try to like get that personal connection with them. Do you have a child, a grandchild? Do you yourself, have you ever walked into a pharmacy and said, I don't know what, I have some ailment, please help?
Yeah.
And try and get that personal connection. I think always having them have the experience is helpful to demonstrate that pharmacists are accessible, but also have the knowledge base to be able to do this limited scope of what we're asking for in the ECAPS legislation.
Yeah.
So, having pharmacists have demonstrated that with our COVID, during the COVID pandemic, having people come into the pharmacy, get tested, and then being able to give them Paxlovid. And there's so much that happened behind the scenes that, people didn't see, but what they did see was the end result of people getting treated for COVID. And so being able to say, wouldn't that be great if we do that for flu, for RSV, for all these other things that are pretty simple to test for, and then to hand you a prescription rather than telling you, sorry, you have to go, to urgent care or call your doctor in order to get a prescription written.
Yeah. I think you have, one of the reasons I was excited to talk with you is that you've got kind of a unique dual perspective from both the payer and advocacy side of the healthcare legislative process. And I mentioned that we continue to get more and more co-sponsors for these bills, and that is exciting. Can you talk from put your advocacy hat on a little bit? Can you talk a little bit about the importance, like what difference does it make that we get more co-sponsors? Like almost every single week, I'm seeing a bunch more folks added on the bills. So what? What does that mean? What impact does that have?
Yeah, so leadership will not take a bill to the floor unless they know it's going to pass, because that doesn't look great for them when it doesn't pass. So the more voices that get added to the conversation who are encouraging leadership to take it to the floor or are becoming co-sponsors, the bigger the groundswell is and to put pressure on those leaders to actually get that bill to the floor. So the more support the bill has, the more likelihood it's going to pass, but also the more pressure is put on to actually get that bill to the floor. If the bill doesn't go to the floor, then it never can get passed. So actually having that support from the legislators is really important to help, because we can all want a bill. We can all support the bill, but if it doesn't ever get to that vote, it doesn't matter. So having them all say that they want it and sign on as co-sponsors is a very important part of the process.
Yeah. Well, so that sounds like actually a tangible, achievable thing that anyone who's listening or watching our conversation here today could actually do, right? Everyone has a local representative in the House, or they've got a senator from their state. And if they're not already a co-sponsor of the bill, you can reach out and encourage them to co-sponsor the bill. And when they do, that improves, it sounds like your perspective, that improves the chance of the bill actually getting a vote and, of course, of it passing. So it's nice that with our government working the way that it's intended, you can actually have an influence and encourage your representative to represent you in the way that you want and actually make a difference in how folks in your community can potentially get access to care.
Yep. It's important. And, the more voices that those legislators hear, the more interested they become. So if you and all your friends and family and all your patients at your pharmacy are calling, then it's more likely that they're going to start paying attention.
Yeah. So one of the things that I think is a significant difference is that we've got this huge legislative opportunity to have a consistent perspective on how to medical bill for a service and your time in the pharmacy to Medicare. And that's exciting, but it's also new. And so in many cases, that's a different sort of endeavor that many pharmacists have undertaken already, and actually doing medical billing for your time and get paid for that encounter. We've talked a bunch on some of our other podcasts and with our other guests, and you and I have chatted a little bit. And there can be challenges there, right? Some folks have tried that and not been successful with some other kinds of services, and some are doing great, and it can make a big impact on their the business of their pharmacy. If you could provide one key tip to anyone who's watching that might be thinking about, hey, if ECAPS passes, now I can start medically billing for the time I'm spending with these patients. What's your one key tip to be successful in that as they look ahead to this hopefully passing?
Yeah, I think it's really important that you do it right, that it actually, the codes that you're submitting to the payer are correct.
Mm-hmm.
You need a medical billing solution that actually can get you to the correct code, to the correct documentation, make it audit proof, so that nobody is coming back and questioning whether you did it right. And unfortunately, we have just billed so differently in the pharmacy world that this is not on our radar, but we have to be able to bill the same way other healthcare providers are billing if we want to do the things that they're doing. So, it's on pharmacy to be able to do it correctly. And there are, partners who can help you do that in a way that's less daunting than, hiring a whole billing department and having specialist coders and things. So it's important that you have the right partner, but it's so important that we get it right.
Yeah. Well, I love sort of your sentiment there is we're asking for the pharmacist to be recognized as at the level of the provider that they are, and to be able to deliver this care that they're clearly capable of delivering that really has a positive impact on the community. But one of the responsibilities that comes along with that is it is a different way of kind of mechanically handling a few parts of the business, including how you get paid. So you have to start medical billing like any of the other providers, which you should be held on par with for these kinds of services, but you can do it. It's possible, and I think it can be just a huge opportunity both for the business of pharmacy, but also the communities that pharmacy is in.
Yeah.
Amanda, it's been great chatting with you. Any other last thoughts or ideas you have before we wrap it up here today?
I just want to say thank you for inviting me on. And, I really do think this is a great opportunity for pharmacy.
Yeah. Well, it's great to have you. I appreciate you joining, and would ask all of our guests to look forward to the next episode of ECAPS Watch.